Yeah, I agree with that. Auctioneer in New Orleans is one of the largest centers because the South does such a good job of donating organs. And then it's set up that, oh, no, all of a sudden the organs harvested in the South are going elsewhere to places with a much larger population, but which do a much weaker job of actually harvesting. And so I agree with the special interests seem to have kind of overridden that, which is, if you see where I'm going with that. By the way, I really enjoyed your technology, your conversation. Dr. Karp, if we have technology out there, the reason you go to the American Association for the Study of Liver Disease or something similar is to learn about the new technology and to adopt. But what you're telling me is that there's an inertia that people are not adopting technology, which presumably gives you a better outcome. Now, that's not medicine at its best. What is the obstacle there?
I think the point's very, very well said. So what we do, as we all know, is life and death, and we get comfortable with doing what we're doing. And so to do something differently is a risk. And for all of us, we need to think about the risk of doing what we're doing versus the risk of not adopting new technology. And I feel that if there was a central oversight that said to the whole community, that says to all of the people that work in transplant, hey, we've got a really good technology here. We've looked at it. It looks like it should work, and it looks like it should work.
But let me interrupt, because it does seem that if you look at transplant survival rates and time on the waiting list, that those statistics almost would give you a market force towards those places that were adopting the more efficacious technology.
No doubt, and that does happen. My concern is that it happens too slowly.
So how can we speed that up? And I guess that's what this hearing's about.
Yeah, but by having HRSA take a broader role, and for example, for the
but let me ask you, because if you're saying HRSA should dictate, the Ronald Reagan quote comes to mind. I'm here from the government. I'm here to help you. Now, sometimes it's actually true. After Katrina, we were very glad to see FEMA there. But that said, we also know that if you start dictating from on high, you may go down a cul-de-sac, as opposed to turns out we have better results over there. So how do we avoid that?
Yeah, so I'm not saying that HRSA should dictate what organs groups use. That's not been part of our policy, and I don't think that it should ever be part of our policy. But for HRSA to say to the community, we have a new technology, we believe it works, and we're going to educate you on how to use this technology. We're going to provide resources for you to improve your use.
Being a group of people, maybe even highlight it more.
Exactly. Okay. Have a central mechanism.
Dr. McGee, from Mr. Wright, we heard that there is over-harvesting, and he suggested that sometimes people harvest organs which are not viable in order to get remuneration. Dr. Karp spoke about organs that should be harvested that are not or otherwise wasted. Can you square that for me?
Certainly. So a good principle here is to respect the autonomy of the donor and their desire to donate. That is what the principal mission of the organ procurement organizations is to do. So they make every effort to try and make sure that wish is carried out. The donors, as you mentioned, market forces could be a factor. It's also what is viable and what is not viable. As Dr. Karp mentioned, there's a great deal of variability of practice across the United States. And that can both be, we can make efforts to standardize that, but at times you can't dictate the interaction of a patient and a physician, and if a program or a place that doesn't have the technology to do something needs to be brought along with that process rather than a simple mandate. So I agree with the points that are made, but I think it's really the process. And as you've pointed out, it's really about the education part of things.
I'm a little rusty on this, but I know that some transplant centers will take an organ that other transplant centers will reject.
100%.
That actually seems like that could be more standardized, unless you're telling me that some with higher volume and greater expertise are able to successfully transplant an organ that another could not.
That is a component of things, certainly, and we don't want to, there's also the recipient in this, or the candidate. So sometimes people can, because of how sick they are, they might need a better organ, and other patients may be able to manage with an organ that is a very good kidney, but not perfect. So I think the other part of this is the pressure on this has made, has brought everyone forward. So I think people have learned a lot. When I finished my fellowship along with Dr. Karp, there are organs now, over half the organs we use now, we were told basically could never be used. So that's progress, and it's bringing everyone forward.
Dr. Karp, you're both, Dr. Karp, you're both an ethicist and a surgeon. There's a friend of mine, Jeff White, a cardiologist, in Shreveport, Louisiana, who thinks deeply about these issues. You mentioned DCT. DCT, tell me again what that is.
DCD, that's donation after cardiac death.
Now, let me just read what he's concerned about. That a person declared dead by the legal standard of irreversible cessation of circulatory function is having their heart restarted. So there seems to be a little bit of an ethical concern about that. Someone is dead, you restart their heart merely to procure the organ to transplant. And so, not brain dead, but heart restarted. How do you address that ethical issue?
Yeah. So whenever we do a transplant, the heart from the donor stopped, and then we restart it. So the fact of restarting a heart is something that we've been doing since heart transplantation started. That fact in and of itself, I think, is just something that we know that happens. When we talk about the donor being dead, there are very careful safeguards around this process. So there are two ways that you can be considered dead: from brain death, and there's basically no brain function. This is how it's generally done, or in the past had been done for organ donation. But more recently, we have this technique called donation after cardiac death. In that case, the patient has basically an irreversible neurologic event. They are allowed to die naturally. The heart stops, and then there's a waiting period of 5 minutes. After that waiting period occurs, then the heart can be, the heart, we can put catheters in and get that heart to start again. But as we do that, we block all blood flow to the brain. And so the possibility of any kind of consciousness is basically is actually eliminated.
I don't mean to be cheeky here, but somebody once said the purpose of embalming is to make sure the person's deceased. Now, in the sense that if you are basically infarcting the brain to induce neurologic death, Dr. McGee, you shook your head no. Is that am I not understanding this? Because it's an ethical conundrum that people are concerned about.
Sorry.
No, please.
I also didn't mean to interrupt. And you're right that that's kind of an absolute marker of death. In the United States, brain death counts and cessation of the heart that is not going to be restarted is another marker. As Dr. Karp mentioned, the goal is to restart the heart. It's just a matter of location. So the key in donation after cardiac death is to make sure they've had cessation of respiratory and cardiac function. The other part of this is in some DCD donors, there's a technique used to reperfuse the blood inside the body, which the key there is to make sure that we do not establish blood flow to the brain. And there are both techniques to that. And in fact, actually, the OPTN in November issued guidance around the best practices of that, which was a clarifying statement. So I appreciate the points, but.
So the guidance from the OPTN is to clarify the possible moral conundrum.
The guidance from the OPTN is to clarify the potential reperfusion of the brain and the upper circulation. The moral conundrum has been discussed for a long time. As Dr. Karp has pointed out, donation after cardiac death and even normothermic regional perfusion has been in the field for 20 years. I published a paper at least 15 years ago on that. So there's been a lot of discussion, and we just need to continue people and engage in honest, open discussion about the ethics of it.
Dr. Karp.
Yeah, and so I would say that the analogy of your embalming is that this is the 5-minute waiting period. So after the heart stops, we wait a period of 5 minutes, and the data suggests that there has been no person in human history that has ever reanimated by themselves after this waiting period. And so that's why we've adopted that 5-minute waiting period to basically assure that the declaration of death is correct, and then the organs are procured.
Senator Moody.